number of people coming in. Again, some familiar faces. Scott, good to see you. I got two Scotts that I know that I'll welcome here. And I will encourage you, we'd love to have you have your cameras on. So feel free to thank you, Scott. I appreciate it. It helps me a little bit to be talking to real human beings. Ivan, thank you. And I know, but some people are eating lunch, so we understand. But um, as we proceed, if you do end up having a question, you can throw that in the chat, and Jessica, my assistant, is going to give me a heads up, kind of has permission to interrupt me as we transition from one slide to the next, and I'll check in with her a couple of times. But we definitely want to make this be interactive, and if you do ask a question, I hope, and we mention it, we'll and we're in conversation. Again, camera really helps. So we'll go ahead and get started. All right. So for those of you who've never attended one of these before, I do these periodically, typically right now about once a month. They tend to be fairly focused on either TEFCA or nationwide data exchange networks in general. And obviously, with a lot happening at TEFCA right now, it is driving a lot of conversation, both related to TEFCA specifically and its impacts on the other networks. So there's a lot to talk about. But I wanted to zero in on individual access services because I think this is something that a lot of people really care about. We have wanted to do it for a while. And also I want to encourage everyone in the chat room, feel free to introduce yourself. We have too many folks to do one-on-ones. But again, use that chat room to do a quick introduction of yourself. So today we're going to be talking a little bit about the past as it relates to patient access to their data through the national networks, kind of past barriers, what things I think are going to be driving better adoption in 2025, and we certainly want to hear your thoughts on that. Introduce some common terminology, take a look at some of the TEFCA requirements specifically around individual access services, and then kind of talking about what might be barriers moving forward, what might cause us to it not to be quite as exciting as I'm personally hoping. So let's go ahead and get started. So this whole mandate to share data with patients really started with this CMS 9115F rule that was published in May 1st, 2020. It feels like it's been around longer than that, but 5 years. And the good news is I think many of us are accessing our data directly through our patient portals, MyChart and things like that. The bad news is, other than that, we don't seem to have made a lot of progress. And I know that's been frustrating for folks. So if we just look kind of quickly at where patient access has been when it relates to the nationwide data exchange networks, patient access, which is what it was known originally under the existing network, specifically Care Equality and Commonwealth, have been an optional use case. So meaning that people can engage in that exchange, and a responder could opt in to a inbound query for patient access. So there was an implementation guide and is an implementation guide for Care Equality. There is for Commonwealth Alliance. The problem is it's been optional, and therefore the responders, where most of that data is, they're simply not participating. And so that's been very frustrating for a number of folks trying to leverage the existing pipes, if you will, that are already well established for treatment-based exchange and have been so successful to not be able to use that existing framework for something that's so badly needed as patient access. I think the other thing that has been a past barrier is some of the biggest EMRs have really seemed to be committed to their patient portals that they'd already invested in. And then, that excuse kind of then became, well, we can do it point to point via FHIR. But again, point-to-point interfaces are hard, no matter what the data specification is. And so particularly those that had patient-facing or consumer-facing apps continue to run into challenges without just devoting a huge amount of effort to build a bunch of API-specific connections across the major EMRs. And the reality is, as a patient, my data lives in a lot of places. I know sometimes I hear people say, well, my data is pretty much all in my chart. Well, for me, I have multiple my charts. I have multiple other EMRs, and my data is fragmented, and it's never been more important to have it not be fragmented. And that's just me, forget about thinking about the people that I'm caring for, my aging mother, for example. So it's really difficult, and it's really important. There was also some discussions when in the early days of the care quality pilot, for example, that the health systems themselves were concerned that the patient app builders were not held accountable to the same level of privacy and security as the rest of the healthcare ecosystem, because they did not fall under HIPAA regulations. And therefore, there were privacy concerns. And I know many of you, I've talked to some of you about this, feel like that's a little bit of, not an excuse, but I do think it is a valid concern. We're dealing with a very innovative sector. Most people have very good intentions, but how do you know? How does a health system know that a particular app has done their homework and is doing the right thing by the patient? So we're going to talk a little bit about how that has changed over the last few years. And then certainly when the Cures Act came along, that was an opportunity for the federal government to step in and say, well, this whole patient access to their data thing hasn't worked out very well. So let's take the lessons learned in current existing private networks and layer in something that has a little bit more of a stick with it in terms of TEFCA, although one would say it's a small stick, and mandate, if you're going to be doing treatment-based exchange, you must respond for individual access services, but we're going to be able, therefore, because we're the federal government, to put some meatier requirements together for the patient app builders themselves. So in order for someone to get certified, an app builder to get certified to ask for a patient's data, it has a lot of hoops to jump through. And it's basically, the whole point of that is to address all of these concerns that the industry had raised across multiple stakeholders. I'm gonna pause for a minute. Jessica, if there are comments in the chat box, please let me know. Or if someone has any comments or things that they want to throw out there, just feel free to unmute yourself and throw out a comment.
Hey, Marilee, it's Scott. How are you?
Awesome. Good to see you, Scott.
Yep. Sorry, like I said, I can't get my camera on. I had some bandwidth issues, so I had to do the same thing with Jim and his call yesterday. So I apologize, but I did want to say one of our barriers to patient access is an app builder, because we do advanced care planning. We want our My Directives users to be able to go out there and query across care quality, for example, or Commonwealth or eHealth Exchange, and find advanced directives and other documents they may have in somebody's system. But we have two barriers to that. One has been the misclassification of those documents historically, not being assigned the appropriate LOINC code document type, for example. So they're going to do a query and they're not going to be able to find anything. But an even bigger barrier to patient access was the identity verification, because the requirements to achieve the level of identity verification historically required things like a driver's license or a credit card or a phone bill or all these other things. Well, our demographic lives in nursing homes, and their children buy them their phones, and they haven't driven for 20 years, so they don't have those government issued identities or credit histories that they, and some of them are suffering from early on stage or even advanced dementia, so they can't answer questions about their past address. So they they can't verify their identity, which is one of the requirements for patient access. And so we're wondering where things stand on that federated model, where, for example, if my identity is verified in person because I've been at a visit with a provider, everyone else can piggyback off of that. So that'll be an interesting topic.
It will, and those are just fantastic points. So I want to just circle back on a couple of them. The first one is the documents that are stored at all these endpoints across the network are supposed to have document types associated with them. And in your use case, the advanced directives type is specifically what, in other words, a patient may be looking for a specific kind of document, or the provider even under treatment-based exchange. And unfortunately, the industry has been terrible at adopting all these different document types and supporting them, meaning they're not, when you ask for a specific document type, they're just ignoring it, basically. And I think that while TEFCA may not be solving